1 minute past 11, so I'm gonna start. There's 35 of us, but I'm sure there's some more going to be joining us as we go along. So welcome everybody to something a little bit different today in our webinars. This is going to be, as opposed to a kind of a lecture or a talk, it's going to be a conversation between two people about the subject of Bing Neel. And for this conversation this morning, I'm joined by two very special people. One is a very clever, articulate and wise lady who cares passionately about WM and all of us who suffer from it. And the other is a haematologist in London. So can I just welcome you to the wonderful Dorothy Hansen and Shirley D'Sa.
Morning, everyone.
Most of you will know Shirley. She's one of our top WM specialists in the UK, and she's known globally also. So it's very special that we've got her with us this morning, giving us an hour of her time. So that's fantastic. So I'm going to hand over to you two ladies to tell us all about Bing Neel, what it's like to treat it and how you treat it, and also what it's like to live with it. So I will leave it over to you, Shirley.
Can I just say first that Shirley, explain to people that Shirley is my consultant. I was diagnosed in 2011 and I've been with her ever since.
Good point. Well said. Over to you then.
Partners.
Over to you, Shirley.
Okay, well, welcome everyone, and a big thank you to Bob and the team at WMUK for organising all these webinars, which are going from strength to strength. Today, we thought we'd focus on Bing Neel Syndrome, which I think is commoner than we realise, actually. I think there's more of it about, but it doesn't always declare itself. When it does, it can be rather sneaky in the way it presents, and one has to actually think about it. So for those who are less familiar with this term, what is it? Well, it refers to the presence of WM cells in the central nervous system. Now, the central nervous system, or CNS, is basically consists of the brain and spinal cord, which are carefully tucked away in a compartment in the body protected by something called the blood-brain barrier. The exact nature of this barrier is not fully understood, but it is there to protect the CNS, actually, because obviously we come across all kinds of toxic materials which come into the bloodstream. And this barrier adds an extra layer of protection. So it's what we call a privileged site in the CNS, in the body. And this has implications in a number of ways, including for therapy. Because when we do treat this condition, we need to use treatments that will cross that blood-brain barrier. Not all chemotherapy treatments do that. So, well, why or how do these cells make their way to the CNS? And who's at risk, and so forth. Now, one thing I will say is there are still more questions and answers. But I think one of the big take-home messages from today is that Bing Neel syndrome is not a disaster if you get diagnosed with it. It's treatable. We can deal with it. There is, of course, a mounting amount of evidence to help us treat patients with Bing Neel. But, and for that reason, because it's so rare, and I think people think that maybe a few percent, perhaps in single numbers, of patients with WM may develop Bing Neel, symptomatic Bing Neel. I mean, when you think about the rarity of WM itself, the proportion of those who may get Bing Neel is really vanishingly small. Having said that, it doesn't seem too uncommon in my practice, because we work together with the neurologists at Queen's Square, and because we have an interest in the area, we get referrals. So we have built up a caseload from about 2 or 3 when Dorothy was first diagnosed to about nearly 30 now. And as I say, they're probably more than that. We don't know why the cells go to the CNS. I think it's worth bearing in mind that WM is an immunological disease. It's a disease, in other words, of the immune system. And if we think about what the immune system is for, it is basically there to send its troops throughout the body. Those troops are our immune cells. And by their very nature, they roam around the whole body, different compartments, different areas, so that they can hunt down bugs and various things and fight back. I guess in some circumstances, because Waldenstrom's is also rather an inflammatory state, and many of the nerve problems arising in Waldenstrom's can result from inflammation caused by the cells and the IgM. One can imagine that the blood-brain barrier may be inflamed in some way in some patients, and that inflammation allows the barrier to be breached, and for some of these WM cells to make their way into the central nervous system and kind of set up home in that area. And that then can lead to an accumulation of these cells, which can give rise, depending on where they are, what they're doing, the rate of accumulation. It can then give rise to symptoms from that part of the central nervous system. So if the cells deposit in what are called the meninges, which is the covering of the central nervous system that surrounds the entire brain and spinal cord, you can get a buildup of what we call meningeal disease. If, on the other hand, they happen to lodge in an area of the brain, perhaps through blood vessels, they may form a small kind of mass or tumor, which can show up as swelling on the brain. Sometimes they are not forming any swellings, but they may circulate within the spinal fluid, which bathes the brain and spinal cord. So when we do a lumbar puncture, that may then give rise to evidence of Bing Neel syndrome. So, technically speaking, Bing Neel is basically WM cells in the CNS. The interesting thing about it is that it can happen alongside WM. In most cases, that happens. In other words, we may see evidence of WM in the bone marrow or the lymph glands, for example, which is very typical for the disease. But it can occur by itself as a first presentation. You may sometimes find a patient who has WM cells in the CNS. When you look for disease in their marrow or their lymph nodes, it's not present. So, they still have WM, but they have the Bing Neel version of it. And also you may see it when the Bing Neel, the WM itself is active and changing and in need of treatment. But you can also see it in people who are not having progressive WM symptoms, but may develop progressive Bing Neel symptoms. So there's really quite a few scenarios in which this condition can occur. But as I say, I must emphasize, we can do a lot about Bing Neel. We can treat Bing Neel effectively. So if you hear about Bing Neel, you shouldn't be unduly alarmed. But equally, if you have symptoms in the central nervous system, we'll, I'm sure, talk about these a bit more, and you're not getting anywhere, I think it's worth raising this possibility to the doctors looking after you. So what I'll do now is I'll maybe hand over to Dorothy to tell us how she presented, because I think you can describe what it was like from your side, and I think that would be really helpful. Thank you.
I have had a series of questions, and what you've just said has covered most of those points. There was just one outstanding one. If you have a BNS episode, are you always deemed to have BNS?
Yes, I guess in this, yes. I mean, I think the thing about BNS, a bit like WM, is once you have it, you've had it. But it doesn't necessarily, so in both situations, you would have the label, but we would say that it's in remission. And the reason to hang on to that label is so that we're aware in the future if things change. We obviously need to monitor people. Whatever they've had at the beginning, whatever disease entities or manifestations they pick up, we need to monitor that. It's a very individualized process. But so anyone who has WM in a certain way, we treat them if they need it. We then follow them up. We kind of keep an idea of what their WM was like, because when it, as you know, if it comes back at a later date, it may behave in a similar way. Having said that, it may not. But likewise with Bing Neel, it is something that once you've had, you have always had, but it doesn't mean it's active. It's a bit like, I suppose, if you've had a heart attack, you would still say you've had a heart attack. You wouldn't sort of scratch that off your record. So in the same way, I think that's the way I would address Bing Neel.
That's good, good. Okay, so I'll just explain what my symptoms have been throughout my journey. I was diagnosed with WM in April 2011. That was done locally. I live in Dorset. At that time, my WM symptoms were much the same as most other people's. I had anemia, extreme fatigue, repeated infections. But at that time, I didn't have any neurological symptoms at all. So I started chemotherapy, CPV mixture, in May 2011. I was to have 6 cycles and I managed 5 of them. But after just the first cycle, I was admitted as an emergency to my local hospital because I had a high temperature, stabbing pains in the back, and I was diagnosed as having pneumonia. It's very strange that I was given intravenous antibiotics, and the next day I started with quite severe neurological symptoms, particularly in my legs. I felt that my legs were very, very weak. And yes, so mainly marked weakness in both my legs. Nevertheless, I proceeded to my second round of chemo, and then I started getting symptoms, tingling in the hands and my feet. Yeah. The doctors who were treating me thought that this was due to the vincristine in the chemo mix, which is known to cause neurological problems, but not normally after such a small dosage. So what they did was they cut the dose of vincristine down by half, but I got progressively weaker. They then left it out for the next round, and I still got worse and worse. I got to the stage where my balance was very bad. If I closed my eyes, I'd fall over. I had a dropped foot on the right-hand side. My right hand was noticeably weaker than the left. What else? I missed it. Oh yeah, I had to walk with a stick because my balance was so poor. Yeah, my husband's here prompting me. I couldn't get up the stairs without assistance. So, you know, my symptoms came on quite suddenly and severely. So my consultant began to get very worried and thought that maybe I had a brain infection, in particular Guillain-Barré syndrome. So I was admitted as an emergency for lots of tests, lumbar puncture, CAT scan, MRI scan, and a neurologist from Poole was brought over to examine me, give me nerve conduction studies, and etc. So the scan showed that there was a thickening of the nerve roots and demyelination polyneuropathy was suspected. But the neurological symptoms were somewhat unusual in that they were asymmetrical, which left the neurologist suspicious that there was something else that he couldn't identify. He knew about Shirley's clinic in London, which was a joint clinic with the neurologist at Queen Square. And he advised that my consultant write to Shirley. And she kindly saw me straight away at the next clinic and agreed that I should be examined by the neurologist at Queen Square. At that time, it was quite an extensive testing procedure. I was in the hospital for nearly 3 weeks and underwent lots and lots of different studies. But the conclusion was that the lymphoma had infiltrated my central nervous system, and I was immediately transferred to University College Hospital to commence high-dose chemo. So that was my first phase. Those were the symptoms then. Mm?
I was wondering, were you going to go on to the second part, or should we maybe have a think about that phase first, or what would you like to do?
I don't mind.
You choose, whatever works for you.
Well, I was going to talk about treatment later, so
Fine,
I'm just
fine, perfect.
symptoms at the moment. Okay,
Absolutely.
So my treatment was successful. I had a good 4 years remission, but then I relapsed in 2016. So I just talk about the symptoms then. They're completely different to the symptoms I had in 2011. I was getting more headaches and my hearing seemed to be affected. So I was referred for tests again, and it was found that whilst I had MYD88 positive lymphocytes in my central nervous system, there was no burden of disease systemically. The CT scan of the chest, abdomen, pelvis, and the MRI of the brain and spinal cord showed that I was stable compared to the position I was in at the end of my first lot of chemo. And a bone marrow biopsy showed that there was no burden of disease in my bone marrow either. So we had this discussion, Shirley, didn't we, about whether to treat or not to treat. Clearly the cells were there, but my symptoms weren't overbearing. And there had just been a new paper, new guidelines on Bing Neel by Monique Minamar et al., and you were part of that study. And taking the advice from that study, we decided that I would be reviewed regularly, but I would not endure high-dose chemo with all the toxic effects that presents. So the next stage in my journey was 2018. In November of that year, I suddenly had an onset of confusion and speech difficulties. It literally came on within minutes. My GP thought I'd had a mild stroke and sent me to the stroke clinic. But when I spoke to you, Shirley, you said, come and see me. So you saw me urgently in clinic and decided I should go back to the neurological hospital for tests. And the brain scan and the lumbar puncture showed that I'd had a significant CNS relapse. Strangely, my bloods were otherwise normal. There was no paraprotein present and no systemic disease. So it's just a considerable growth of cells in my central nervous system. So I was admitted to University College Hospital again in December for another lot of high-dose chemo. And I should mention that by this time, both my husband and I realized that I had considerable decline in my cognitive skills as well.
Spatial awareness.
And
spatial awareness.
Oh, and my spatial awareness as well. Sometimes I just didn't know where I was, even though I was going somewhere that I was very familiar with. So these were unusual and quite different symptoms. So those were my symptoms at the time. I know there's a lot more symptoms, Shirley, aren't there? A lot of patients present in quite different ways to me.
Absolutely. And I think what it represents is that the brain and you know, has so many functions, which it normally just gets on and does. But if the cells of the brain are interfered with in some way by the presence, for example, of these lymphoma cells or WM cells, there comes a point when they show signs of that. The fallout affects the brain function. And it was interesting because at the beginning, as you say, Dorothy, I mean, notably, you had quite marked peripheral symptoms, you know, affecting your legs and your walking. And I think we were looking very much at peripheral neuropathy And there was evidence of that as well at the time. And this is another thing to mention. I mean, we have these artificial labels for our bodies, so we say the central nervous system, the peripheral nervous system, and so on. But actually, biological processes don't really care for those labels. They do their own thing. And we need these labels to help us understand these conditions, subclassify them, talk to each other about them, write them up. But we have to also have what I'd like to say is plasticity of thinking when we see patients, because things don't adhere to our goalposts. They do their own thing. So I think in Dorothy's case, yes, there was evidence of inflammation of the peripheral nerves, possible involvement by Waldenstrom's, also the nerve roots, which are where the nerve roots come off the spinal cord at all levels, really. The spinal cord is a long, sort of tapering piece of tissue, and nerve roots come off all the way down to supply our arms, our legs, etc., etc. So I suppose once those nerve roots exit this blood-brain barrier and come out of this compartment where there's CSF floating around, then I guess they become peripheral nerves. That's our artificial distinction. But what we found in many cases actually is that Bing Neel can affect the central nervous system. It can affect the peripheral nervous system at the same time. Sometimes it doesn't cause peripheral nerve symptoms and they're more central. I think the thing is anything is really possible. And the symptoms of Bing Neel are almost infinite, because it just depends where in the brain or spinal system, etc., the disease decides to take root. The other interesting thing was, this question of vincristine, which is a drug very widely used in lymphoma practice, and is effective. It's an important drug for many lymphomas. It's not something we recommend at all in Waldenstrom's. And this is something we're trying to get the word out to our colleagues who are very used to using it in other lymphoma settings. The reason is that people with Waldenstrom's do have a tendency to get peripheral nerve problems. And so by including vincristine, we might accelerate some of those problems through the treatment. So that's number one. But obviously, this was many years ago, and that kind of decision hadn't quite been put into practice. And so Dorothy was given a very reasonable treatment for her Waldenstrom's. And so it was no wonder that the clinicians thought, could the vincristine be damaging her peripheral nerve? So it was a very reasonable thing to think. But I think the important thing for me was that it didn't quite fit because of the timing. Vincristine tends to cause problems in a progressive way as you go along. Her doctors had taken the right decision to reduce the amount of vincristine, but still she got worse. So I think a big rule of thumb is that if things don't fit, we have to keep looking and delving and trying to understand why that is, and not simply accept and almost make a prejudgment and stick with it, because at the end of the day, whatever's happening to the patient is what actually counts. So we looked hard and we did find evidence of central nervous system involvement. And we then decided to go on, obviously, we'll talk about treatment in a second, but I think the other thing about the symptoms is that in 2016, when Dorothy presented with headaches, and we found evidence of CNS disease by virtue of cells that we looked at under the microscope, as well as looking for, I know there's been a question about, how do we know cells are present are due to WM? Well, let me first of all start by talking about a lumbar puncture. A lumbar puncture is taken from the lower end of the spine, just south of the spinal cord in a space, because obviously when you put the needle in, you don't want to touch the spinal cord. So about the fourth and fifth lumbar vertebral space, or third and fourth, we put a needle in under local anesthetic. We get fluid dripping into a bottle, and that is analyzed under the microscope to look for any cells. We look at the protein of the CSF, which should be within certain limits. If the protein is very raised, then there's a suggestion of inflammation. Now, that could be due to a lymphoma, it could be due to infection and other inflammatory conditions. So it's not specific for Bing Neel. But we then put that together with other features. If there are cells present, we look at those in some detail. Are they white cells? Is it a blood-stained tap? Because you can prang a blood vessel when you do a lumbar puncture. And if you do that, then you may see a lot of red cells, and white cells may be there with them. And so if you detect those white cells, they may not actually be living in the CNS at the moment. They may have come through your needle, actually. But if there's an excess of white cells, then we look to see, are they neutrophils, which are the cells that protect against bacterial infection? If they are, then we would think more along the lines of meningitis. If they're lymphocytes, then they could still be due to meningitis. When you have viral meningitis, your body tends to produce lymphocytes as part of the immune response. But usually with meningitis, there are other symptoms. It's usually a sort of quicker onset. There's usually fever and neck stiffness and things like that. So if we see sort of in a cold setting, no fevers, no infections, someone presenting with progressive features, then a high lymphocyte count is suspicious for lymphoma. But how do we prove that? Well, we do tests on the lymphocytes. There's one called flow cytometry, where we isolate those cells and we pass them through sophisticated machines, having labeled that sample with the number of what are called monoclonal antibodies. So we look for cells we know may turn up in CSF, such as B cells. There shouldn't really be lots of B cells in the CSF under normal circumstances. Really, there may be a few if there's inflammation, but there shouldn't be a large number of the same kind of B cell. And that's exactly what we can look at using flow cytometry. We can look for IgM, IgG, or whatever. We can look for kappa and lambda. And if we see that they are restricted, then we get the information that they are actually clonal B cells and they are likely to be lymphoma. Now, sometimes we don't see many of these cells, and that might be because there aren't many. It might also be because patients may have had steroids to help settle them down. That can then suppress the B cells, the lymphoma, temporarily, and may make the diagnosis more difficult. So what we also do is to look for the MYD88 mutation in the CSF and other signs, some genetic features called heavy chain rearrangement. So that's like the IgM. So we have a molecular test that we do if we suspect Bing Neel Syndrome. So you can actually interrogate the CSF in quite a sophisticated way. But at the end of the day, what we're left with is, it depends what there is in there. So you may have Bing Neel and still have negative CSF readings if your disease is more lumpy or if it's stuck to the meninges. So this is a process in the setting of potential Bing Neel. We do follow this rigorously in every case. And I think certainly because I work so closely with the neurologist, we've developed a kind of a system for checking to see if someone has Bing Neel by doing all these tests. And sometimes people will have had a lumbar puncture in the local hospital, but they may not be able to do some of the extra tests. And that's why we often would repeat those tests in an individual like Dorothy had. She came up and had another, half a pint of CSF removed or something like that to test for. So that then we have to put, so yes, we can look in some detail at the CSF. The other thing to remember, of course, is that one has to look at the central nervous system using scans. And the best scan to look at that is actually an MRI, which is a magnetic resonance imaging scan. MRIs are very good at delineating soft tissue changes. And by using certain what are called sequences, you can show up certain things like the fluid, or you can show up the nervous system tissue, etc. So obviously it's quite a specialized process, and I myself wouldn't interpret such scans. They're done by radiologists. The important thing to remember with an MRI scan, though, is that if you do a lumbar puncture before an MRI, you can get a reactive change in the meninges. So this is a bit technical, I'm sorry to mention it, but it is of practical significance because it's really important, if at all possible, the MRI is done before lumbar puncture if someone suspects Bing Neel Syndrome, because otherwise you get a false negative kind of inflammatory look to the central nervous system, and that can make things difficult. Now, in some circumstances, it's not possible. So you may go to your local hospital on a Friday night or something, and they may not be able to wait till they do an MRI. They may do a CT scan to make sure it's safe to do a lumbar puncture. So these are the kind of things that can come to pass when you're trying to work someone up for Bing Neel. So scanning is very, very important. And again, it does need expert review. And that is why we do have a specialist clinic and what's called an MDT, multidisciplinary meeting. And many, people do refer in, and we're very happy to see cases if investigations are started locally. So I guess the bottom line is, because the symptoms, as Dorothy has delineated, are so diverse and not even the same the next time around, we kind of have to look very comprehensively at the central nervous system whenever we suspect Bing Neel, either at presentation or at relapse. And as Dorothy said, you can get confusion. You can even, some people I have some patients who were felt to be developing dementia, actually. And, sometimes they're of an age where that is not a crazy thing to think about. But I've increasingly, if someone has a background of Waldenstrom's, I have increasingly decided, if someone presents in this way, we should probably image the brain. We should probably consider a lumbar puncture. Because if you can find something to treat, that is far better than labeling someone as having dementia, because you can reverse that dementia. Now, I have some cases where exactly this has happened. People have had cognitive decline sometimes over several months, and they've been really quite dependent on help and so on. And with successful treatment of their Bing Neel, they've literally returned back to normal. Others have actually had quite significant psychiatric symptoms, and they have come back to normal. So, there's everything to play for in finding this condition. Really, really important. And I think from my point of view, I know it's easy, in a way, easy for me because I'm geared up to do these things, and it's very much in my mind. But for those of you who are, under many teams in wherever you are, I think this awareness is important, and raising it with your clinician, because many clinicians simply haven't seen Bing Neel syndrome, and they might think it's a crazy idea, but perhaps. But I think highlighting the fact that it can be very diverse in its presentation, but really important to pick up, because we can treat, that I think is the key thing. So any atypical symptoms that you're worried about, please be a bit of a nuisance wherever you are and say, look, I'm not happy. You may have a test and it's ruled out. Perfect. But if not, then it's very treatable.
Good. Shall I talk about my treatments then, Shirley?
Yeah, I think that would be a good thing to move on to. Yeah.
Yeah. So in 2011, it was decided I would have high dose chemo, and I had the Idaram mix, which contains mainly methotrexate, which crosses the blood-brain barrier. Is that right, Shirley? Yeah.
Indeed, yes.
Yeah. So I had 4 rounds of that. It involved me staying as an inpatient in University College Hospital for 3 weeks at a time. But it was very effective. I had a considerable improvement in my neurological symptoms from round 1. My drop foot was hardly present after the first round of chemo. And then I got a progressive improvement in my neuropathy with rounds 2 to 4.
Hearing came back.
Hmm?
Your hearing came back.
Oh, and my hearing came back. This is a bone of contention, really, because the ear, nose and throat people refused to accept that there was any link, but I personally feel that there is. And if my hearing goes, I get worried, that it's coming back heavily again, but there we are. I had a post-treatment joint review with you, Shirley, and Professor Riley, who was then dealing with the side of things. And she said that the repair of my nerves had been remarkable, but I shouldn't expect any further improvements. But my physio, who I had privately, said, do we accept that? No, we don't accept that. So I had, he and I worked very hard to achieve what amounted to about a 95% improvement, which is phenomenal, really, when you think how affected I was. Incidentally, I met Robert Kyle at an international WM conference, and he was asking me about my story and commented that I was an extremely lucky lady to have recovered so well. You know, and it was because I had my BNS diagnosis so soon after I displayed neurological symptoms. So, as I mentioned before, in 2016, when I relapsed, it was decided that I wouldn't have any further treatment at that stage, because the only real option, I think, Shirley, at that time was chemo, wasn't it?
Yeah, that's right.
Ibrutinib wasn't an option for us in the UK at that time, was it?
No.
So I went on until I had these this confusion, etc., in 2018, and it was decided I should have high-dose chemo again, and I had the matrix regime this time, again with methotrexate. So the treatment was administered in isolation in your hospital. And then I went into ambulatory care to recover, which was a much, much better system for me. It meant I didn't have to spend the whole of the 3 weeks in hospital. I was meant to have 4 rounds of chemo, but I only managed 2. I felt extremely poorly from the treatment, and my organs began to be affected. So I had another MRI and lumbar puncture, which showed that there were persistent lymphocytes in the spinal fluid, but the number of cells had more than halved because of the 2 rounds of chemo. Shirley felt that I'd had a very good partial response, and she didn't want to blast me with any more chemo that was going to make me very ill. So we decided that the result of the first 2 rounds would be consolidated with Ibrutinib. And I've been on Ibrutinib since March 2009. 2019, thank you, Richard. To date. And recent blood tests show that I don't have any paraprotein, and I'm just waiting for the results of my last brain scan. But certainly I feel very well. Lots of side effects from the Ibrutinib, but you know, it's better than the alternative. So there we are.
Thanks, Dorothy. Great account, and reminds me what had happened over the years as well, which is interesting. I think. So I guess this brings us to, you know, how do we treat Bing Neel syndrome? What is the optimum management? And there is no consensus, even though there are guidelines which were published back in 2017. There are many effective therapies, but the question is how hard do we hit a patient to get these cells? Because at the end of the day, we can, you know, in our cupboard of treatments, we have a range of things, but we need to try and match the intensity of the treatment with the scale of the problem and the person themselves. They may be fit, they may be frail, you know, all of that has to come into account. So I guess the way to look at Bing Neel is that basically, this is low-grade lymphoma, indolent, slow-growing lymphoma in the central nervous system. So a bit like in the treatment of Waldenstrom's, where we borrow from, you know, it's a form of lymphoma, so we use lymphoma agents to treat systemic Waldenstrom's. We do the same when it turns up in the central nervous system. And so when Dorothy, back in 2011, had this so-called IDA-RAM chemotherapy, this really comprised primarily methotrexate, which is one of the main things that helps to penetrate the blood-brain barrier, but also something called cytarabine or Ara-C, and another drug called idarubicin. Now, all of these do cross the blood-brain barrier. And at the time, there had been quite a few publications using this IDA-RAM treatment for CNS lymphoma. And at our center in the early 2010s, we were using this as our regimen of choice. Now, I must mention that treatments like IDA-RAM and the other one that Dorothy more recently had called Matrix, which also consists of methotrexate and Ara-C, rituximab, and another drug called Thiotepa. I wouldn't say they are terribly widely used in the Bing Neel setting because they are developed really for high-grade lymphoma problems, so-called primary CNS lymphoma. Now, high-grade disease is, again, another topic for another day because it's not something that usually affects WM patients, although there are a subset of patients who can have what's called transformation. And when the disease becomes more aggressive, it can be very much like something called diffuse large B-cell lymphoma. I don't want to dwell on that. That's something we can perhaps talk about another time, this so-called transformed disease. When I talk about Bing Neel, I'm not referring to the transformed disease setting, but we have still borrowed and continue to do so from that setting for the treatment of BNS, because at the end of the day, for the treating doctor, the challenge is to obviously induce a remission. Well, take one step back, only treat when treatment is needed. Secondly, when treatment is needed to induce a remission, which we hope will last as long as possible so that the person doesn't need further treatment for this problem for as long as we can get out of it. So we do at UCLH do think about hitting patients who are fit enough quite hard because I think, in my idea is that we have a patient with this particular presentation. If we can gain a very good deep response, then hopefully they'll be treatment-free for a longer period going forwards. Whereas if we start off with not under-treating, that's perhaps the wrong word, we may end up needing to go back to treatment quite quickly. So this is not it is relatively contentious, and this is something we are constantly reviewing in our own practice. We very much select patients who we think can receive these high-dose chemotherapies. We have made some adjustments to the dosages of these treatments, depending on the patient that we have, depending on their disease and how it's behaving, whether it's relatively subtle or whether it's really progressive and quite fast and burdensome. So it's very much work in progress. But at the time when Dorothy presented 2011, there was no such thing as Ibrutinib. And even in 2016, Ibrutinib was around, but was not available in the UK. It came on the CDF in 2017, the Cancer Drugs Fund. So we used what we felt was the best thing for her. And I think, to be honest, given that Dorothy's symptoms were actually quite progressive and disabling, we felt that we really wanted to reverse the process quickly as well. And I think, the improvement that she had from the treatment was very good to see. And then she had quite a long remission before she developed some new symptoms. And if I remember correctly, Dorothy, did you develop those headaches when you were coming in on a plane or something? And did you have some headaches then? Or was that in 2018? Or
no, that was 2016. Yeah. I had flown for the first time since I've been poorly, and I was quite ill on the plane coming back. And the air stewardess said, "Have you been drinking?" I said, "I certainly have not been drinking." And I just started getting more and more headaches then, and then this ear problem as well. I sort of, You always said to me that I think you'll know when it's come back. And I think at that stage I felt something had changed. So, yeah.
Yeah. I mean, I was speculating at the time whether, you know, the thing about the fluid in the brain area is that it moves around, it circulates. And if, you know, if there happens to be some kind of cellular debris building up, it may block the movement of the fluid. And perhaps that may have become more problematic when your, you know, the altitude changed as you descend in the plane. You know, I'm speculating, but at any rate, it drove us to retest you at that stage. And indeed, we did find evidence of Bing Neel present, but actually, I think your symptoms settled. And we had a discussion about it with the neurologist as well, and felt, look, actually, if Dorothy isn't broke, let's not fix her right now, because, you know, there are cells there, but the wisdom in managing low-grade lymphomas is if they're not actually causing an impact, let's not rush to treat, because, and as we see with Dorothy, there was another 2 years before actually the disease progressed. And of course, then, yes, it was quite florid. But she was spared treatment for 2 years and remained well under close review. And we were kind of poised to treat whenever, but actually she was fine. And so that's, you know, a case in point where just because cells may be present to the CNS, which you may, you know, we may find for whatever reason, we wouldn't necessarily, we still treat for the reason of whatever the patient has wrong with them, not just because we see an abnormality, or not just because the IgM goes up or whatever. It's down to what is the impact on the individual. That's what drives us to treat. Now, the second time round in 2018, we had actually moved away from Idoram because a new treatment called Matrix had undergone quite extensive testing, again, in the high-grade setting, the so-called primary CNS lymphoma setting. And this was the treatment of choice in our institution and remains, because it hasn't, you know, it's still a really well-regarded treatment. And so we do use it. We've made adjustments to the dose again, because people do question, you know, my colleagues, for example, you're using quite a heavy treatment for a low-grade disease. Is this, you know, the rationale for this, etc.? So I have to be honest, it is a work in progress. We don't yet know the answers, but we've had some very good results with Matrix. And as I say, we take a case-by-case decision depending on the individual. So quite often now what we do is if someone appears to have quite a heavy burden of disease, either in their CNS, their lumbar puncture, or on the scan in terms of size of swellings or whatever, and have rather progressive disease, which is affecting them functionally, we would tend to start with something like Matrix, which we'll probably adjust. So Matrix, just to remind you, M is for methotrexate. The A is for Ara-C, which is another treatment that crosses the blood-brain barrier. T is for thiotepa, which is another treatment that crosses the blood-brain barrier. And the RIX or whatever, it's actually rituximab, good old rituximab, which is helpful in joining in with other treatments. So we would tend to use 1 or 2 cycles of Matrix. We would tend to repeat the lumbar puncture and the imaging and everything else. Obviously, take account of how the individual is doing. Are they improving? Are they, you know, they feeling better? Are they getting functionally better or not? And then at that point, either go on to complete further Matrix up to 4 cycles, and even consider a stem cell transplant as consolidation. And by that, I mean, once we achieve a remission, we're trying to hang on to it. And to be perfectly honest with you, if someone presents with Bing Neel syndrome in their 40s, I would consider hitting them quite hard, because the remission I want, we want that to last decades and decades. And we want it to last decades in everybody, but we do consider quite a heavy approach at our center for Bing Neel, even though it is low-grade disease. But these decisions are very much taken in a discussion group. We don't simply do this so we're monitoring our treatments where it is controversial, but I think, it's been very helpful in some of our patients. But I will move briefly now onto the good old BTK inhibitors. The most famous, if you like, is Ibrutinib, because that's the index drug, the first one that came on the market and is still there. is a very effective treatment for Waldenstrom's, and in the context of Bing Neel, does cross the blood-brain barrier. People have done studies on this, and we've also seen people improve clinically in reports who've only had Ibrutinib therapy. So we do use Ibrutinib as well, and in Dorothy's case, for example, she had 2 lots of matrix. It was pretty heavy going, probably because, you know, she had had prior heavy chemotherapy in the past. And while she had recovered from that, you know, when we re-challenged, there was sort of memory in her system for this powerful treatment. And I think, again, she needed a pretty quick reversal kind of fortune, and that's why matrix was started. But then we were very, very happy that we had Ibrutinib that we could then move her across to maintain this response. So yes, as far as we also know that Zanubrutinib, which is another drug which some of you may be on because it's been in trials, crosses the blood-brain barrier. There have been reports of Bing Neel responding to Zanubrutinib. And there's no reason to think that Acalabrutinib wouldn't. I'm not aware of any reports, but I dare say there may be some. But this class of drug does cross the blood-brain barrier. And so the question to us as treating doctors is, you know, when do we use this as opposed to chemo? We don't know the answers yet. I do still think it's an individualized decision-making process, depending on how the person presents, the burden of their disease, how progressive it is. And importantly, we also have to take account of whether they're burdened with a lot of systemic disease at the same time. Now, in Dorothy's case, she didn't have much going on in the systemic compartment. So we were able to simply target her Bing Neel and not sort of worry about the other disease. But in some people, they have active Waldenstroms in their marrow and active Bing Neel. And so we wouldn't only give someone CNS-directed therapy because that's not the best treatment for their bone marrow. So we might consider a combination, or we may, you know, Ibrutinib would treat the whole caboodle. So we might target first the CNS and then consolidate with Ibrutinib, etc. So I think, again, there's no absolutely clear-cut way of doing these things. But the message is that many treatments do cross the blood-brain barrier. What about other traditional chemo? Well, bendamustine is used for many people with Waldenstrom's. Some colleagues, for example, in the Netherlands, have used bendamustine successfully in Bing Neel. Our own experience is relatively mixed. I wouldn't use it as my first choice. I think we did recommend Benda ahead of something more intensive in a patient because of COVID and a lot of other things going on. So, and things like DRC, probably less likely to be useful in this setting because you need quite a high dose of cyclophosphamide, which is part of this, is the C in DRC, to cross the blood-brain barrier. We wouldn't really use that as a treatment of choice in Bing Neel. The other thing to bear in mind is you can actually deliver treatment directly into the spinal fluid through a lumbar puncture. It's called intrathecal chemotherapy. And we can give drugs like methotrexate and Ara-C into the spinal fluid to help clear lymphoma cells that are circulating. So sometimes that is used as well.
I actually have some intrathecal.
Yes.
First time round, yeah.
Yeah. So again, that's not, you know, we again decide who we should use different treatments in and for how long. And you know, at the end of the day, the objective is rather patient specific. And you know, if someone has very aggressive disease that's really impairing them, then we kind of come out with quite a heavy-handed approach. Whereas in someone who has more slow-burning disease, we would consider an ongoing, less intensive treatment in such patients.
Shirley, I've got a question here that someone submitted. Is it possible to have a complete response with Bing Neel syndrome? So
I think technically, I suppose it all depends on how you define complete response. So there are response criteria that are designed for Waldenstrom's, and there have been similar ones devised for Bing Neel. I think the thing one has to remember is what we call low-grade lymphomas, like Waldenstrom's. The reason they're not regarded as curable is because it's very difficult to eradicate every last cell, even when you give someone very intensive therapy. And that's why I think all of you will have been told you've got something that can be treatable but is not curable. The same, I believe, applies to Bing Neel. I think we can certainly label something as a complete response, because if someone presents with whatever it is they have, they may have the meninges may be showing up, they may have cells in the spinal fluid, they may have something on the scan. Once we've treated, we can look again at all these parameters and we may find no evidence of anything. The scan may have cleared up. The fluid may have normalized, the paraprotein may be negative in the blood even. Yes, in that situation, we would call it complete response, because by our criteria, there's no longer any detectable disease. But I'm not sure, in my own mind, I would never, to be honest, equate that to a cure. So I would always bear in mind in the future for that patient, they have had this, it could be problematic in the future. So I think you can get a complete response, but I think using the word cure is, I think, perhaps difficult to say until enough time has gone, and who knows what that time is before we can say it's cured.
The other questions we've had is regarding prognosis and survival. Once diagnosed, how long will I live? Difficult one.
Well, I have to be honest. When we make a diagnosis of Bing Neel syndrome in a patient, I never feel fazed by that. And the reason is because what I feel, I look upon it as another manifestation of Waldenstrom's. I think we all know that Waldenstrom's is a very multi-talented disease. It can cause all manner of havoc in different ways. It can accumulate in the bone marrow, it can enlarge lymph nodes, the spleen, the IgM can get up to all sorts of mischief. It can go into the central nervous system. So in my mind, Bing Neel is a form of WM. It's reached the central nervous system. We have ways of treating it. And so I don't look upon it as a particularly poorer prognostic factor in WM. It is basically another manifestation of the WM disease. And like yourself, you were diagnosed a long time ago with Bing Neel syndrome. Look at you. You're notwithstanding the hammering we gave you with the treatment, you've recovered so well. You're on Ibrutinib, like many others are for WM itself. So I don't think the prognosis is particularly different than if you have WM itself. It is another string to the bow of WM, which we seek to clip if it rears its ugly head. So we just need to use the most appropriate therapy. But more importantly, we need to find it first. That is the key thing. The prompt diagnosis of Bing Neel is important, which comes back to those symptoms. If you have symptoms that are worrisome and you can't put them down to things and they're a bit odd, don't be put off or sort of if someone says, no, it's nothing. I'm not suggesting you worry yourself to death and push for every headache you get. You should, in your own mind, if you feel things are out of character and strange and yet progressive, then it's worth having someone look into that a bit further. As to how long you live for, well, again, I look upon it as the same as WM. Whenever someone is diagnosed with WM, I expect them to be knowing them for many years, decades even, and I think it almost begs the question of when did the whole thing start? When we diagnose WM, it happens to be at a point that either it declared itself because it's produced some clinical effect on the person, or it was found by chance. It probably started many years prior to that. So the kind of time scale for WM is tricky because we don't know when it actually started in the first place. So I look upon it as, some unknown some unknown time where you first develop the cells that are WM, then a point when it was diagnosed for whatever reason. And then the next time point is when you start treatment for the first time. So these are the milestones in WM. And then in my own mind, I find that that's a useful clock to sort of press the button on. Once you start treatment, you're in a new phase of the disease. And the key thing then is about giving the most appropriate therapy in the right way, particularly important for Bing Neel, and, you know, keeping the options open, being aware of possibilities. I guess the only thing I would mention, which I made a note of to talk about with Bing Neel, is that quite often having Bing Neel is an exclusion criterion for clinical trials, which is a bit of a nuisance because, you know, but in a way one can sort of understand, because if a trial is being developed for treatment of WM, one has to measure response, one has to then report that response. If it's complicated by Bing Neel as well, then it makes interpretation of that trial much more difficult. So by definition, most people with Bing Neel are generally excluded. There may be some newer trials coming up which do not exclude Bing Neel, so we are obviously always on the lookout for that. But I guess the main thing with Bing Neel at the moment, the benefit from trials has been that we can use Ibrutinib in Bing Neel syndrome. As long as there's been one prior therapy, those rules still apply. So yeah, I mean, I think with BTK inhibitors available for Bing Neel, you know, I think even then the prognosis is now making its way up to be even with the rest of WM, to be honest.
Good. The last.
Oh, sorry, go on.
Are we finished, Bob?
No, you carry on. You carry on.
Right. The other area I wanted to cover was how much patients should be told about their disease. I've spoken to a lot of WM patients, and quite often they've been very unhappy by the lack of information that's been made available to them. I mean, not all patients want to know the detail of the disease, but from the outset, I and my husband certainly did. But personally, I feel it's unreasonable to expect our doctors to go into great detail tutoring us on our disease. They just don't have the time, I don't think. Information was in very short supply when I was diagnosed, but there is so much more information available now. And I did find that IWMF and WMUK were of significant help to me. I mean, within a couple of months of my initial diagnosis, I was getting copies of the Torch magazine from IWMF, and WMUK were very, very helpful. In particular, I'd like to thank Roger Brown for all the help he gave me and Richard at the outset. You know, he knew an awful lot about what was going on in terms of research, and you know, the 2016 guidelines, he managed to get me a copy of those before they were even published, and that helped me to understand my disease. So yes, thank you, Roger, and for all he's done for WMUK over the years as well. Yeah. And I just want to mention that I don't know whether all the Bing Neel patients in the UK are aware of the fact that there is an IWMF extraordinary Bing Neel club that Julie Davidson compiled, and there are 44 members at the last count. So if you belong to that club, you know, if any information comes up on Bing Neel, then, you know, Julie and her colleagues will send that to you. So that's very, very useful, I think. The other thing, before COVID, we attended as many WMUK conferences as we could, and also a couple of the international conferences. And that was very, very informative. And latterly, many local clubs have been set up with the help, with Bob's help, and that's proved to be very successful. So there's much more information available now.
Well, thank you for that, Dorothy. And we've been going now for just over an hour. I'm conscious that Shirley's got a clinic this afternoon. So I don't want to keep her for too long, but I've just got one question I don't think was covered, and it can be dealt with, I think, pretty quickly. Can Bing Neel be treated with CAR T therapy? CAR T therapy is something that we've got a lovely lady going to talk to us about very soon. But Shirley, is it something that CAR T therapy can have a look at?
Not specifically. I mean, to be honest, even WM itself as an entity is, there are some preliminary studies on CAR T, but I think my honest impression, because there's a CAR T group at our hospital and many others, the focus is on some other disease areas at the moment for various reasons, not because they don't want to deal with WM, but because I have to be honest, there's still a fair amount of refinement to happen in that setting. And so it is employed more readily in a way in very aggressive diseases like diffuse large B-cell lymphoma or acute leukemias, because that is a really tricky, dare I say, do or die situation for some patients. In low-grade lymphomas like WM, I dare say there will, I'm sure Maeve O'Reilly, my colleague who's going to do this webinar with Bob, will be able to tell you more, but it's not at the current time available, but it has been used in CNS lymphomas. So that's the answer to that.
Okay, thank you. Just a couple of points that have jumped out at me. One is, Shirley, when you said, this is for the people in the UK, because I know we've got many international guests with us this morning, which is fantastic. But for the people in the UK, you said, Shirley, be a nuisance, and this is something that I keep talking to anybody that I talk to about, is especially for those of us outside of London or outside of the specialist centres like I am in Bournemouth, is to be a nuisance. Be a nuisance with your haematologist and ask the questions, and especially with Bing Neel, if you've heard something this morning, I think that makes you think, well, I wonder if I've got Bing Neel. Then, and I'm thinking particularly of a gentleman who's on this meeting from Wales. I won't name him, but he'll know who I'm talking about. Is be forceful when you go and see your doctor and your clinician, and talk about Bing Neel and ask if it's something that you can be checked for. Is that something that you agree with, Shirley? Very
much so. Yeah, no, I think so. I think it's a very, it's a difficult entity because it's rare, and WM is already rare. And so, although, some of us, we do actually end up seeing a lot of it, and it seems quite commonplace, but literally, if you think about the number of patients that a hospital in a district general a consultant in a district general would see, they're small numbers. Bing Neel is not the first thing that will jump into their head. They wouldn't have seen it. To be honest, they wouldn't have had a chance to read all about it because there's so many things that hematologists have to know about. So I think if you raise it as a possibility, that'll help to spread the word. And I would say and hope that no one would be offended by that. I would hope that people would take that as a good prompt to look into further. I think most people would, to be honest. I think they would say, fine, let's look into this. And there is some literature out there for them to look at as medics. But yes, I think please stick to your, most people know themselves well enough. Please just stick to your guns, really. And you can reach out through WMUK as well if you're not getting anywhere, because we can always see what else is possible and help you on this front.
Thank you. And something else that's jumped out about from this meeting this morning, it's not necessarily to do with Bing Neel, it's about, you've alluded to it quite a lot, is we tend to beat ourselves up about the numbers game. We talk about our IgM and our hemoglobin, and we're obsessed with numbers, and I am guilty of that, definitely. But it seems to me the more I learn about this is you as clinicians, yes, they're important, but our quality of life is as important or even more important, and the way you decide on our treatment plan and when to treat us and what to treat us is our quality of life. Is that a fair comment?
Absolutely. I think, to be honest, I think you as patients are not the only people guilty of the numbers game. Obviously the numbers have come up and are important because they form the basis of the way we measure response. But many doctors, many hematologists also think about the numbers game. And I've seen many patients who were started on treatment for their Waldenstroms because their IgM went from this to this. And when I asked them, look, how were you feeling at the time? Were you, did you have more symptoms? Were you more anemic? And many of them said, not really, but I was told that my disease was progressing, so I started treatment. So I'm honestly trying to get the word out there, both to patients and clinicians, that there's much more than the numbers, because I have a patient, for example, who's an IgM of paraprotein of 50 grams for about 7 or 8 years. And he's actually fine. And I've learned to accept that, because initially I was falling off my chair thinking, oh my God, better get you in for plasma exchange and everything. But when I talked to him, he was actually fine. He was fine. And I've not yet found a reason to treat him. So the numbers game, yes. I mean, it's good to be empowered, good to be aware of your trends and so on. But at the end of the day, the symptoms are what counts. The effect it actually is having on you, that is what counts. And sometimes that actually, you need to be a bit brave to say don't have treatment. And you need to be brave to accept that you don't need treatment, even if numbers are changing. But what we do have on our side is the ability to retest in a month or 2 months, or, and keep an eye on the symptoms in parallel. And for sure, jump on it the moment everyone feels that there is enough going on to merit treatment.
Okay, thank you. And just finally, Dorothy, I want to just say how encouraging you joining us this morning has been. I don't have Bing Neel, but I know a lot of you guys watching have Bing Neel, and I think I've known you now for 6 years, and you're an incredible lady. And the way you talk and the way you present yourself outside of your treatment, we wouldn't know that you have Bing Neel. So
thank you, Bob.
It's a credit to you, but it's also a credit to the treatment and the clinicians. And some people, again, in the UK may be looking on and saying, oh yeah, but she goes to UCLH in London. But we're from all over the place, and we can all get this treatment if we talk to our doctors correctly. So well done to you, Dorothy. I just want to say a big thank you to all of you who have joined us this morning. I know we've got people from Holland, we've got France, the US, Australia, Belgium, even Scotland. That's a joke, by the way. Welcome to our friends in Scotland. I love you, really. So just a big thank you. I hope we've covered most of the questions that you sent in. If we didn't, I apologise for that. But just a big thank you to you, Shirley, for giving us what is now an hour and a half of your time today when you've got a clinic to get off to. And to you, Dorothy, thank you so much for doing this. I know you were a little bit apprehensive. Just remember, guys, this was a conversation between a doctor and a patient, but it was done in, I think, a very proper and appropriate way. And thank you, Dorothy, in particular, for allowing us to hear and share your story. So, guys, thanks very much indeed. Shirley, goodbye.
Thank you. Bye to everybody. Take care.
Dorothy, goodbye.
Bye.
To everybody else, goodbye.